Hello everyone, my name is Islam and I'm a recent graduate from Eastern Medical University, Multan, Pakistan. I am currently rotating at the Cleveland Clinic with Dr. Faiz Anwar, and today in this lecture we're going to talk about definitions, diagnostic criteria, and the risk criteria based on which we decide what's the risk of progression from these precancerous conditions to the multiple myeloma itself. All of these three conditions are basically plasma cell disorders. So let's start with what are plasma cells. Plasma cells are post-germinal center mature B cells. They recognize the antigen and undergo changes producing antibodies. And plasma cell disorders are basically abnormal proliferation of these plasma cells. They replace the bone marrow and produce monoclonal antibodies, or M protein as we call it. These antibodies can either be IgG or IgA, IgM, most common being IgG, and second most common is IgA. Multiple myeloma is almost always preceded by a asymptomatic non-cancerous condition called MGUS. MGUS is monoclonal gammopathy of undetermined significance. It can then progress to smoldering multiple myeloma and then multiple myeloma. Smoldering multiple myeloma is a milder form of multiple myeloma which is asymptomatic. It just means a flame which has not been set to fire yet. The risk of progression from MGUS to myeloma is almost 1% per year, and from smoldering multiple myeloma to multiple myeloma is 10% per year. This slide shows the range of conditions MGUS can progress to, including myeloma, Waldenstrom's macroglobulinemia, Poem syndrome, which is quite rare, and other conditions. These are the routine labs we do for patients with suspected plasma cell disorders. It includes SPEP, UPEP, CBC, creatine for kidney disease, calcium, free light chain ratio, which is a ratio of kappa and lambda light chains, skeletal survey to check if there is bony involvement, and bone marrow biopsy for checking the percentage of plasma cells. This is an interesting sign called Shaka sign. It just helps you remember what each bump on this SPEP means. So the first one is, the taller one is albumin, and the next to it is alpha 1, alpha 2, beta, and gamma. So the gamma proteins actually represent the antibodies we are looking at, IgA, IgG, IgD, E, and M. So in monoclonal gammopathy, there's a sign called M sign. So if you see the gamma portion of it is taller, it just creates an M. That's what it means. Serum free light chain ratio is another test we do for plasma cell disorders. It's basically a ratio between quantity of kappa versus lambda light chains in the serum. Normal range is between 0.3 and 1.5. If it's greater than 1.5, it means kappa light chains are in higher quantity, and if it's lower than 0.3, it means lambda light chains are in higher quantity. And it helps even if the disease is non-secretory. So if the quantity is not that high, but the difference in the two light chain types is abnormal, it can help us diagnose the disease. And it may not always be positive because it's reabsorbed in the kidney. And if the kidney function is deranged, then it can create false positive because lambda light chains are in the form of a dimer, so it's not absorbed very well if the kidney function is not okay. So, so it's affected by the renal dysfunction. This slide shows types of the antibodies, and the total light chain assay, it measures all types of antibodies including light chains, but the free light chain assay measures only the light chains. So as we talked about in the previous slide, the lambda is in the form of a dimer, so that's why it's not absorbed well if the kidney function is deranged. Now let's talk about diagnostic criteria of MGUS. It's based on revised International Myeloma Working Group diagnostic criteria. So MGUS is basically when on bone marrow biopsy plasma cells are less than 10%, and monoclonal protein levels is less than 3 gram per deciliter, and protein levels in urine is less than 500 milligram per 24 hour. And most importantly, there's no myeloma defining events or amyloidosis. We're going to talk about myeloma defining events in the future slides. Here's the diagnostic criteria of smoldering multiple myeloma. Again, there's absence of multiple myeloma defining events or amyloidosis, but the M protein levels is as high as multiple myeloma, which is more than 3 gram per deciliter, or M protein levels in urine is more than 500 mg per 24 hour, uh, and plasma cells on bone marrow can be 10 to 59%. The diagnostic criteria for symptomatic multiple myeloma includes two things. There's greater than 10% plasma cells on bone marrow biopsy, or there's bony or extramedullary plasmacytoma, plus one of the myeloma defining features, which is slim crab criteria. So this is the slim crab criteria. Crab, as most of us know, is C stands for hypercalcemia because calcium is being displaced from the bone. If there are any bony involvement, and R is for renal dysfunction. We measure that by measuring creatinine, and A is for anemia, and B is for bony lesions. And in SLIM, S stands for scans, which can be MRI or PET scan or a low dose CT scan. MRI is done for any soft tissue involvement, and LI stands for light chain ratio. If the ratio is greater than 100, we straight away diagnose it as multiple myeloma. So that's why these are called myeloma defining features. And the third one, M, stands for marrow plasma cells. If percentage is greater than 60%, we diagnose it as myeloma. We don't uh, go further for classify as at MGUS or SMM, do any further testing. So this table summarizes the diagnostic criteria we just talked about. If here again, if any of the myeloma defining features is present, we diagnose it straight away as multiple myeloma, irrespective of the M protein levels in serum and urine. And for the bone marrow plasma cells, if it's lower than 10%, it's classified as MGUS. If it's 10 to 59%, it's classified as smoldering multiple myeloma, because if it was 60%, it would satisfy the slim crab criteria. So it would then be classified as multiple myeloma. How common is MGUS? It's fairly common. If population is older than 50 years, it's 3%. If you screen population older than 50 years for MGUS, you will find it in 3% of the people. And in ages 50 to 59, it's 1.7%. And in greater than 70, it's actually more than 5%. So what is the risk of progression for MGUS and smoldering multiple myeloma to multiple myeloma? So the risk, the graph for MGUS is pretty linear. It's 0.5 to 1% risk of progression each year. So if you have the diagnosis of MGUS, there's 1% chance that it can progress to multiple myeloma, and even after 10-15 years the risk remains same. But once you have smoldering multiple myeloma, the risk is not very linear. It's higher in the early years of diagnosis, and it keeps on decreasing. So in the first 5 years, it's 10% risk of progression. In the year 6 to 10 years, it's 3%, and in if you had the diagnosis for more than 10 years, it's just 1% chance. So That's why it's important to stratify these conditions based on their risk, because we need to stop before they involve end organs. So there were two studies, I stop multiple myeloma. It was held in Ireland, and the other was PROMISE study, which was based in US. Both of these trials, I-STOP MM and PROMISE study, these are an attempt to find out what should we do to stop the progression. Should we screen all population for multiple myeloma or plasma cell disorders? So the I-STOP MM, it was held in Iceland. So all participants were screened for these conditions with SPEP and free light chain ratio. So if the screening is normal, then there's no follow-up for them. If they are diagnosed with multiple myeloma, then they are treated for it. And if it's MGUS, then they are divided into three arms. One arm had no further workup, second one was based on guidelines, and third one had intensive follow-up. The PROMISE study is based in the US. They screened 50,000 people and 47,000 were negative. The 3,000 who were screened positive, they were followed up for 5 aims, like developing new biomarkers for diagnosis, advanced risk stratification, and new tools to stop the progression of MGUS to a multiple myeloma. This is a risk stratification model called Mayo risk stratification. So each point is given to a feature. If isotype is IgA, it's a high risk feature. If M spike concentration is more than 15 gram per liter, it's also a high risk feature. 1 point is given. And if FLC ratio is lower than zero point 0.1 or greater than 10, it gives us 1 point. And if uninvolved Ig is below normal level, it gives us a point or two. So if 0 to 1 point is low risk, and intermediate risk is 2 points, and high risk is 3 points or higher. This graph visualizes risk of progression based on abnormal factors. So if FLC ratio is normal, the risk of progression is the lowest. IgG subtype is not a high risk feature, and if M spike is lower than 1.5, then these features are lowest progression risk. And if any of the high risk, if just one high risk feature is present, then higher risk of progression. If two factors are abnormal, then higher than that, and so on. These are the risk stratification models for smoldering multiple myeloma. The first one is Mayo Clinic model. It is also called 20-20 model. And the second one is Spanish myeloma group model. And then there's International Myeloma Working Group model. This table compares three risk stratification models for SMM. So first one is Pathema model. Immunoparesis gives us 1 point. It's when uninvolved immunoglobulins are suppressed, and if abnormal plasma cells are more than 95%, it gives us another point. And Mayo Clinic model is 20-20 model. If 20 more than 20 FLC ratio, and if bone marrow plasma cells are more than 20%, it gives us 1 point each. And M protein concentration more than 2 also gives us 1 point. And similarly, there's a range of FLC ratios at M proteins and plasma cell in International Myeloma Working Group model. So below this table, we can see risk of progression at 2 years for each risk class based on these models. These are some more high risk features for progression of SMM. So if abnormal plasma cells are more than 50%, that's a high risk feature. And on fish, if there's some genetic abnormality like 1q gain or 17p deletion or T414, that's also a high risk feature. And diffuse abnormality or a focal lesion on MRI, which we do for soft tissue. If there's a focal lesion but no osteolytic lesion, that's also. And in IgA or IgG SMM, Benz-Jones proteinuria. So this graph and table shows risk of progression for SMM to multiple myeloma. So there's 6%, 22, 45, and 63% risk uh, corresponding to risk factors 0, 1, 2, and more than 3 risk factors. This is a staging system for multiple myeloma, revised international staging system. It's based on beta-2 microglobulin, albumin, LDH levels, and findings on fish. So if beta-2 microglobulin levels are less than 3.5 mg per liter and albumin is more than 3.5, LDH normal, and if there's none of these abnormalities on fish, then it's stage 1. And stage 3 is uh, beta-2 microglobulin more than 5.5 and LDH elevated, and there's stage 2 when it's neither stage 1 or stage 3. So this is from 2015, this staging system. We have some new revised staging systems. This is the second revision of international staging system done in 2022. So it does include staging system from before. If you had stage 2 or stage 3 from that system, it gives you 1.5 point each. And then LDH levels and 17p deletion, 1q gain, and T414. So below here it shows total additive score and the risk group based on that. This table summarizes some of the high risk and standard risk features for myeloma. Some of the abnormalities found on fish are standard risk and some of them are high risk. So high risk one includes 17p13 deletion. If it was gain, it would be a standard risk feature. And T414, T1416, and 1420 are high risk. Gain of 1q is high risk, and LDH levels more than 2 times the upper limit is a high risk feature. And features of plasma cell leukemia and high risk gene expression on profiling is a high risk feature. Thank you so much, everyone, for your time and attention.